Uh, Good evening, everybody. Uh, I would like to thank the organizers for organizing such a wonderful conference at an exotic location and inviting me here and the opportunity to present. So, the topic today is de-escalation of treatment in endometrial cancer. And so, we'll start straight away without wasting any time. So, this is the first case. A 62-year-old female presented with post-menopausal bleeding. DNC was done outside. Biopsy was adenocarcinoma. So I would like to start with Dr. Sunny Khanna. What is the modality of choice for biopsies of suspected endometrial CAs?
So in this age group, any post-menopausal bleeding we suspect adenocarcinoma. Now the biopsy has been given. So the first imaging I would like to do is a contrast lens.
No. I'm going to say, how do you biopsy? What do you prefer? What method do you
prefer? A hysteroscopy biopsy.
Hysteroscopy biopsy. So anybody will disagree with that?
Practically we do dilatation in curettage.
DNC.
Yes.
You don't do the
90% of the time the patients comes to me with the biopsy. Otherwise they do.
Okay, so as surgical oncologists, we are not trained in endometrial biopsies. Using the pipette.
So I am trained from Adaya Cancer Institute. We generally do every Saturday. We have a list for only dilatation and curettage.
Yeah, we ourselves do DNAs. But then yes, the endometrial biopsy as an office procedure is pretty easy provided we learn it. So since we are discussing de-escalation, we have to discuss de-escalation in all aspects.
Yeah, after imaging, you can see if it is a bulky growth, if it is going to be.
So how would you image, Dr. Sami?
So I would like to image with a MRI, contrast lens MRI of pelvis.
Okay. So the MRI showed well-defined, minimally enhancing intracavitary altered signal intensity growth, around 3 centimeters in size, and there's no evidence of myometrial or serosal invasion, and few subcentimetric size nodes are noted in the pelvis. So anything further you would like to do? Apart from MRI pelvis, how would you stage the patient?
If there is suspected pelvic nodes which are appears to be involved, then go for further staging on the CT apparatus in thorax.
Okay. So any role for PET scan?
I think in this case, MRI is sufficient.
MRI is
it's looking like a
MRI.
early stage disease, so MRI is sufficient.
Okay.
I think only MRI pelvis is there. We can adjunct with CT abdomen pelvis.
CT abdomen is there.
CT chest is not required. CT chest X-ray is more than enough.
Okay.
And regarding the PET, the guidelines doesn't recommend directly for any PET. If you suspect any systemic disease, extrauterine disease, bulky nodes are there, then you can do the single modality of investigation PET.
Okay. So, Dr. John, what is the extent of surgery and the components of surgery you would like to?
So, this radiologically looks like a disease which is 1A, so which is only confined to the nerve of the myometry. So, I would go for total abdominal hysterectomy with a bilateral salpingoophorectomy along with the peritoneal cytology and peritoneal biopsies. The extent of because there's no nodes and radiologically it's a very early disease, I wouldn't go for a pelvic lymph node dissection or a parietic lymph node dissection.
And central lymph node?
Central lymph node, yes, I will consider central lymph node for this patient.
So the surgery, we performed an open surgery in this case, the TVH and DSO, and bilateral pelvic lymph node dissection was done. And surgical staging, lumpectomy, peritoneal biopsies, pelvic washings were done. We didn't do a parietic lymph node dissection. Dr. Shivkumar, when would you do a parietic lymph node dissection?
Yeah, before that, I think other option would be minimally invasive, laparoscopic, or the revolution of robotic. If robotic is there, definitely you can go for robotic.
Yeah.
I don't have robotic, so we do minimally invasive laparoscopic staging with sentinel lymph node biopsy. We do.
Yeah.
We do now ICG dye. We do with an ICG, and we do the sentinel lymph node biopsy. Regarding the parietic lymph node dissection, there are two schools of thoughts. Some routinely do systematic lymphadenectomy, but evidence says there is no role for systematic lymphadenectomy in an early endometrial cancer. And if in a sentinel lymph node biopsy there are parietic nodes uptake is there, we have taken samples from parietic nodes. If that frozen section is going to be positive, I go for parietic nodal dissection. Otherwise, I don't do routine parietic nodal dissection.
Okay, parietic lymph node dissection is the clinician's discretion, I would say. And so the technique of you use ICG, and I mean my colleague does it. We use methylene blue and the reactive type. But then I think ICG is gradually replacing and is becoming the gold standard across the board.
So I would like to ask one.
Yeah.
Because only mention adenocarcinoma. We don't have the grade of the tumor.
Yeah.
Basically, I would like to know whether adenocarcinoma is endometrial adenocarcinoma or it was high-grade histology was there or not. So that was not mentioned in the
Yeah,
biopsy.
it was not mentioned.
So until we know this, we cannot plan whether we are going to do a lymphadenectomy at all or not, or we are going to do a sentinel. That will depend on the grade of the tumor and the what histology we are dealing with. So if it's endometrioid and it is grade 1, grade 2, I would like to go for sentinel. And if it is a high-risk histology like serous clear cell, whatever adenocarcinoma, then I would not go for the sentinel because it is coming up, but it is not recommended actually.
I think you have something to say.
Yeah, I think previously when we start off with sentinel lymph node biopsy, they say only for endometrioid, low-grade tumors. Now, even serous carcinosarcoma, and even for high-grade, we can go for a sentinel lymph node biopsy. We have an imaging. If the imaging shows a bulky nodes, we are not going to contemplate on any sentinel lymph node biopsy. If you have any suspicious of lymph node, for example, if you do a sentinel lymph node biopsy, if that site there is no uptake, you have to go for a, practically it is difficult actually. To start with, we started doing initially 10 cases, we completed the nodal dissection because we want to standardize. Then now we started slowly, so a few numbers, but we started slowly doing it. Practically it is difficult. And it is still still standardized in our part actually.
So what the
routinely?
Momental biopsy. Previously, when we were a postgraduate, we do momental biopsy, peritoneal biopsy, sun wash cytology. Now, gradually, the staging is also changed. I think peritoneal washings is no more indications for any adjuvant therapy or something. So,
yeah, but the peritoneal washings need to be recorded.
Yes.
To be done.
If it is an institutional policy, definitely momental biopsy, peritoneal biopsy, and washing is not going to add on to any morbidity.
For very early cases of endometrioid endocarcinoma, a routine omentectomy is not recommended anymore. However, it is recommended if there is extrauterine disease or any other histology.
Yeah, so the serous histology, clear cell,
yes.
carcinoma.
So, what you brought up a very important point regarding the bulky lymph nodes. Actually, these lymph nodes, they don't take up the time. So, unless and until the uterus is big, if the uterus is big and it's difficult to actually do a sentinel. So, in that cases, or if the lymph nodes are bulky, then you would not go ahead with sentinel from biopsy.
Even if I am doing the sentinel, if I find a bulky node, I will have to remove it.
Yes, you have to remove it. Yes. So this is the algorithm for Dr. Shiv Kumar just mentioned that even if there is no uptake on a particular site, then you have to do a full lymph node dissection on that side. So this is the algorithm mentioned in the NCCN. So this is the methylene blue dye, and the next is the ICG by robotic. These are again my colleagues' images. So HPE, what points to look for? I would like Dr. Yadav, can you please?
We would like to look for the grade of the tumor,
Yes.
depth of invasion,
Yes.
any lymphovascular invasion is there, and what is the histology actual, like histology, and status of lymph node and other washing and all momentum if we have done it momentarily.
Yes.
Otherwise, all these features we have to see.
Okay. Dr. Saptashi, LVSI, lymphovascular invasion. Since we don't have an oncopathologist over here, so people have to shoulder this. What do we mean by lymphovascular invasion, focal and diffuse? And what is considered over here when we say present or absent? Satyajit Kumar. Dr. Arnav. Dr. Arnav.
Neurovascular invasion, the impact is, if it is positive, then there is a chance of pelvic nodal mates, or that disease can come back in the pelvis. So, in LVI positive cases, some sort of radiation is indicated, mostly EBRT, that is the external beam radiation.
Yes, thank you. The LVI and age greater than 60 have been regarded as a risk factor as per the latest guidelines. And LVI, when we say LVI present or absent, we refer to a diffuse LVI, that is more than 4 sites in one slide, rather than a focal place where lymphocytic invasion is present. So, what is the adjuvant, any adjuvant required in this case? Age is 62.
Based on the HP, I don't think this case requires any further treatment. Surgery alone should be enough.
Okay. Thank you.
So age was more than 60. So I think we can consider for brachytherapy. Intravaginal brachytherapy. Everything is fine, but
Yes, both observation as well as brachytherapy. It can be vaginal brachytherapy can be considered.
at our institute we go for brachytherapy.
Okay.
Is age an independent?
Yes, age or and LVSI in grade in stage in 1A endometrial cancers is an indication for vaginal brachytherapy. Yes, ma'am. As per the latest guidelines, age is a criteria. You have to combine all the three, but even one is enough for it reduces the local. See, observation is category 1, and I think vaginal brachytherapy is 2A. So we can debate this, until the end of time. So yeah, so this question is again Dr. Abhishek. Do ITCs upgrade the stage when we do an alter staging of central infant biopsy?
For ITC, it doesn't upgrade the stage, but if it is a micromet, we can consider.
Yes, but ITCs need to be recorded. And
it should be documented,
yes,
definitely.
it should be documented. So moving on to the second case. So this is very, very controversial. A 33-year-old lady with infertility and Paris being treated for 10 years for this infertility, 89 kgs, had metrorrhagia since 10 years. Ultrasound showed endometrial thickening 20 mm with polycystic ovaries. How do you move forward, Dr. Devlin?
This patient is obese, young, and has endometrial thickening 2 cm and has polycystic ovary. We actually refer this case to a gyno-oncologist surgeon for an endometrial biopsy.
Okay. So we did an MRI for her. They showed polypoidal submucosal lesion which is filling the endometrial cavity with a broad base. There were no significant lymph nodes. There was no muscle invasion. We did a DNC, showed adenosquamous carcinoma. The patient was desirous of fertility preservation. So I referred her to a clinical oncologist. And is there any role for conservative management over here?
Conservative management is usually for endometrioid histology, low grade, with none of the risk factors. If patient is very young and is very strongly desiring for fertility, then maybe some hormonal treatment. But I have not really done in my practice. We have opted for surgery and then treatment in these cases. Theoretically, it is possible.
Okay, Dr.
Yeah, actually, it has to be properly counseled that it is not a standard of care. Standard of care is surgery if it is an adenocarcinoma. But like Madam said, it's a patient is desirous of, and the other criteria of it, patient has to be counseled. It is not a standard of care. We have to send it for a fertility department for the other counseling part, and we have to keep them under a surveillance protocol. There's a strict surveillance protocol, 3 monthly DNCs and or by endometrial biopsy. If there is a progression, then we have to go for an immediate surgery.
Yes, point taken.
Is it for adenosine histology as well?
I don't know. If it is a malignancy, it is not a standard of care.
We don't have any oncopathologists over here, but then we had done a tumor board for this patient.
Should be grade 1 and
Yeah.
endometrial without any myoinvasion.
Yeah.
Strict criteria is there, but
Agreed.
Adenosoma is
Because
aggressive
is-
histology.
We did a tumor board and we did a slide review, and then the adenoscomas carcinoma is a type of endometrioid carcinoma wherein the behavior of the tumor depends upon the adenocarcinoma grade and not the squamous carcinoma grade. However, the squamous carcinoma along with adenocarcinoma is more common in high-grade adenocarcinomas. But this one case was well differentiated. So we offered her medical management, however, and we started on resistance. She developed bleeding 3 months after starting hormonal treatment, and repeat MRI showed advancement of disease, and then we did a complete THBSO and then surgical staging. So would you agree with the procedure we have done, Dr. John?
Because you have definitely failed after 3 months, you have go ahead and done a staging,
Yeah.
and she has got lower involvement of the cervix also.
Okay.
So now she requires adjuvant because it's definitely into.
Yeah, this is histopathology report.
Yeah, the pathology report, you've done an adenocarcinoma grade 2 with invasion of cervix, and less than half of the myometrium is involved. But already because of the invasion of cervix, she goes into high risk.
Okay. So, what type of hysterectomy would you do? A type 1 or a type 2, Dr. John?
Type 1 hysterectomy, or I think it depends. If you can get a vaginal cuff of margin, that will be pretty.
This is a invasion of cervix.
So, yeah, type 2 hysterectomy.
Type.
Ideally, if it is only restricted to the endometrium or myometrium, we go for a simple hysterectomy type 1.
Yes.
If the preoperative imaging shows it's a cervix involvement, lower uterine segment, or cervical involvement,
Yes.
definitely it's a radical hysterectomy.
Dr. Jatin, we removed both the ovaries. So, would you agree with this procedure?
Yes, sir. In this case, I agree.
Okay. Can we preserve the ovary in cases of endometrioid cancers of ovary?
We can.
We can.
Yes, sir.
Okay. There is a roughly close to 5 to 10% incidence of tumor being there in the ovaries along with the uterus. But then there are studies also which say that preserving the ovary may be safe. But then this is a very dicey situation.
Need counseling and go for
Yeah.
a transposition of ovary since these patients need an adjuvant radiation.
Okay.
Removal of ovaries is also associated with decrease in survival.
Okay. Why would you say that?
Because ovarian functions is important for.
Okay, what do you mean for that?
physiology is important. Other hormones are
Okay.
important.
Okay, so my next question is what type of radiation therapy would be given, sir?
I think we can go with only vaginal cuff brachytherapy.
Yes. So we overtreated her. We gave external beam and then
Is it stroma or only
no, there was stromal invasion. So we treated her with external beam RT and followed by 2 sessions of brachytherapy. So who are the candidates for fertility preservation, Dr. Shiv Kumar?
Discussed. If it is an endometrioid and low grade, and they understood it is not a standard of care, it's more important. And if that is so, on patient should be for under strict surveillance.
Yes.
If the criteria fits, we can go for a fertility preservation with the hormone therapy.
Okay. So if any of you have a personal experience with
No, I don't have any personal experience, but just to add on well-differentiated grade 1 endometrioid, also it would be wise to do a Lynch syndrome rule out because the whole mechanism of action of Lynch is mismatch repair and not based on hormone. So you're basically trying to give progestins to suppress the tumor or make it respond. But in Lynch syndrome, the whole mechanism of action is different. So probably ruling out Lynch for those cases we are planning for fertility preservation also would be a wise idea.
Okay. So the best technique, is there a need for hysteroscopic excision? So since we can only rely on the literature, we don't have much.
They say that hysteroscopic excision you can add on with any IUDs or progestins.
Yes.
So basically, it's not just hysteroscopic excision. You have to add on with.
Yes, you have to start with
hormone.
distance, but hysteroscopic excision, if it can be done, people are doing it. So this is case 3. A 56-year-old patient presented to the OPD. The surgery was done by a gynecologist outside, and then he calls up Dr. Shiv Kumar, and she calls up Dr. Shiv Kumar and says that, "Doctor, I've done a THBSO and the report is endometrial cancer. Please do something. Don't open her up." So how do you proceed? Please.
Yeah, I will get into the details of what previous images has been done. And this is a patient is on table or it is?
No. I mean,
With the report the patient is sending to me.
it's come to your OPD.
Then I will look into the previous imaging if it is taken.
Yeah.
And get all the reports. What is the pathology report? Slides and block I will review in my institute. With the experienced pathologist, I will check what is the grade, what is the type, and based on that I will take a call.
Okay.
And if the imaging is not done, then we have to repeat the image.
Okay. So this is the histopath, the review.
Carcinoma, grade 1, primary invasion, LPSA, invasion of cervical stoma, ovarian, unremarkable. So there are high risk features, LVSI and invasion of cervical stoma. Ideally, I will counsel the patient for. I will look into the notes. Imaging. What about the imaging?
Yeah.
Few enlarged lymph nodes in the pelvis, largest 1 centimeter.
So any role for PET scan over here?
No. If you properly done CT abdomen pelvis, I don't
No,
think
your colleague calls up and tells you that, doctor, why don't you do a PET scan? If there's nothing, then why do we just leave it and then we can get away with
if
our.
you say by guidelines, not required. Practically, if you ask me, I will look at CT.
Yes. So 1 month, 4 weeks after surgery.
This is practicalities because I don't need to screen. I screen entire chest and everything.
Yes,
That's the idea.
So I personally would do a PET CT in this case, but then surgical staging with PLND and para-aortic lymph node dissection was done, and the biopsy report was as follows: lymph nodes positive, 2 on the right side, 1, 2, 3, 5 HP, PT2 and 1 G1. So how would you go about?
In this case, I think we better treat the patient with concurrent chemoradiation followed by brachytherapy.
Ma'am, chemotherapy, role of chemotherapy in this case.
This I would like to give that 43 protocol here.
Okay.
CTRT and then 4 cycles of chemotherapy.
Okay. CTRT followed by 4 cycles of paclitaxel. Okay. Okay. So, is there any role for classifying this as per the genomics and proteomics, these sort of cases?
So, as per the molecular classification,
Yes.
currently it's in the trial stage.
Yeah.
There are 4 classes as we know. So, some of them are prognostically better subsets, but this is stage 3 disease. I think CTRT chemo is the way to go as of now, until we have further results.
So basically, the future is going to see a paradigm shift in the treatment of endometrial cancer. And endometrial cancer it came into the limelight only after the publication of the result in the newspaper about the immunotherapy, wherein the disease vanished in quite a few patients. So there are 4 types of endometrial cancers, namely all mutations, the MSI deficient or MMR deficient or copy number low, P53 copy number low, and P53 copy number high, in which patients with all mutations do very well. Ma'am, you want to say something about this as to how it will impact the choice of adjuvant therapy. So,
Yeah, so there are these two classes of tumors, these pole ultramutated tumors and the MMR deficient category tumors, which do very well biologically. So probably the early stage cancers where chemo might not benefit as well will have de-escalation of treatment, but we have to wait the results of this voted for, and a lot of trials is going on in this. Currently, as of now, it doesn't change our treatment.
Currently, as of now, it doesn't change. It hasn't exactly integrated into the standard NCCN guidelines.
Like they're looking into the role of immunotherapy as well in early stage disease.
Yeah.
Like in stage 1 and stage 2 disease where we are giving only brachytherapy. So there's a trial also going on patients who are MMR deficient who are receiving pembrolizumab in addition with radiotherapy and see how it works. So if it's a positive trial, maybe practice will change in near future. But as of now, the standard practice is what we follow in our clinics.
Okay. The MSI,
the deficient MMR subset.
Yeah, they don't
these
respond.
are they actually respond very nicely to immunotherapies.
Yes.
And these are prognostically also very good tumors. They have a good behavior, biologically good tumors. So apart from radiation, there is also a trial going on, radiation with pembrolizumab to see how it works. And so maybe in the future we'll have a different standard of practice. But as of now, these all are in the stage of clinical trials.
Okay, so this is the last case.
Just to add on, basically pole mutation is like a get out of jail free card. Even if you have node, what they're saying is even if you're node positive, high grade, whatever the stage, you don't give any adjuvant, pole mutation, ultramutated, very good prognosis.
Yeah.
Worst is copy number high, and somewhere MSI high is somewhere in between pole and copy number high.
But in fact, pole mutations are the ones in which
High grade.
Yeah, the high grade and quite advanced with deep in muscle invasion, and yet the prognosis is good. Dr. Gandhi, would you like to add something? Abhishek? It's not. So this is the joint statement by the European guidelines, and we see stage 1 and 2 pole mutated endometrial carcinoma with no residual disease has been classified as low risk group. This came out in 2019, and no radiation, no adjuvant is recommended in these patients.
So the only problem with pole is you have to have NGS or Sanger or Hotfoot. But for the others, you can do it with IHC,
Yes.
MMR and P50.
Yes.
So the cost for pole mutation will be around 18,000.
That's
That will be a problem.
Even the NCCN recommends that for all cases of endometrial cancer, we get them evaluated for these mutations. We'll study the genomics and the proteomics, but then it is not cost feasible at present. So take home messages. Anybody would like to sum it up?
Probably for endometrial carcinoma, early stage, not the advanced stage. Early stage de-escalation therapy in the form of open to minimally invasive, I think, is the way forward, and robotic, I think. Because the advantage of doing sentinel lymph node biopsy is better with open compared to laparoscopic. The haptics and view and it's excellent with robotic. If robotic facilities available, I think the de-escalation will be surgically with early stage endometrial cancer. And regarding the nodal, there comes the de-escalation. How we risk stratify the patients, still it is an area of controversy. And we have preoperative imaging, intraoperative. There are some, if the pathologist is experienced or we have a frozen section, we can cut open the specimen and you can do the staging and you can decide on nodal dissection. That is the way of de-escalation is there. And I think the way forward ahead for the adjuvant therapies, I think this molecular is the way ahead.
Yes. So there's an 80-year-old patient who underwent THBSO and then is being planned on immunotherapy. Didn't get the data because they didn't have all the slides. wanted to put it for this case. So they straight away immunotherapy after surgery. But then obviously it is all under consent, and because yes, it is not the standard of care. Okay, thank you so much. Thank you.